This lecture is brought by Dr. Ki Jung-hong, an assistant professor of the Seoul National University Burame Medical Center. In this presentation series, we'll be looking at basic information and EMS variables of PATOS. We'll first take a look at variables about demographic information, injury epidemiology, pre-hospital care, and inter-hospital transfer. First is demographic information. As you may all know, PATOS variables include core, comprehensive, and optional datasets. In this lecture, we'll mainly talk about core and comprehensive variables. Core variables for demographic information include research institute, country, case ID, date of birth and age, gender, and EMS district or city. Comprehensive variables include residential postal code and citizenship. Demographic variables can also be divided into two parts according to the source of information. Variables about research institution include country, EMS district or city, and name of the institution. These variables will be consistently recorded across all cases from each site. Second part would be information about a patient, which would include case ID, date of birth and age, and gender. Case ID in this case would be a registration number given to PATOS cases, and it is different from the patient registration ID provided by your institution. For research institutes that wish to collect comprehensive variables, we need to have additional research on patient residential zip code and citizenship status. Information on residential area and citizenship are indicators for estimating a patient's socioeconomic status and availability of trauma care resources in the residential area. These information would in turn tell us about their accessibility to medical service, language barrier, and clinical outcomes. Now, some countries may not have clear definition of citizenship as other countries do, and some may not have postal code system. In this case, please discuss with your country PI and enter the data according to the alternative criteria developed for your country. Next, we'll move on to injury epidemiology. Core injury epidemiology variables include date and time of injury, intent, mechanism, location, type, and place of incidents. We also need to collect information on the type of activity during incidents, alcohol use, psychoactive drug and substance use, arrival type, and level of pre-hospital care provider. Comprehensive variables include postal code and address of the incident site, whether the injury was occupational, and whether of the day when the injury occurred. For those who were not patients but were directly involved in the incident, we will collect two optional variables: their alcohol use and psychoactive drug and substance use. We aim to collect these injury epidemiology variables as much as we can because these variables can help us better understand the patterns of injury, its distribution, and causation. Doing so can help us reduce the socioeconomic burden of injury. Based on these kind of injury studies and research, we can develop successful strategies for reducing both the occurrence and severity of injury. We will take an example of a patient with an injury and his medical record to find the PATOS variables. Information will be mostly found in his medical notes on present illness. Let's take a brief look here. A 65-year-old male visited emergency department on June 11, 2015 by emergency medical service from the scene. Doctors and EMTs of EMS transported the patient after fluid resuscitation. He suffered low extremity fracture and open wound of thoracic wall caused by traffic accident at 6 p.m. yesterday. The traffic accident occurred unintentionally on the street while he was heading to work. He was not drunken and did not use psychoactive drug, but he did not undergo a blood lab test to assess his ethanol or drug level. Now let's find our PATOS variables in this medical record. If you take a look at the blue part, we see that the patient visited the emergency department on June 11, 2015. But the date and time of incidence was 6 p.m. of the previous day, so that makes the date and time of injury June 10, 2015 at 6 p.m. The red letters show us that the pre-hospital care was provided by doctors and EMTs. For arrival type, the green part tells us that the patient was transported by EMS from the scene, so the patient is not regarded as inter-hospital transfer. We'll now review the location of injury. According to his medical record, it showed us that the patient had lower extremity fracture and open wound of the thoracic wall. So the blue parts show us the location of injury, while the red letters tell us the nature of injury. Mechanism of injury in this case would be traffic accident. For place of injury, the patient suffered from a traffic accident, which obviously occurred on the street, and it would be regarded as an unintentional traffic injury. As the patient had the accident on his way to work, this would be considered a work-related injury. About alcohol use, the record shows us that the patient was not drunken at the time of incident. For PATOS, alcohol use and drug use can record suspected use, which will be provided in the medical record, or confirmed use, which will be based on blood test results. We'll go into more detail about this later in the presentation. The green part shows us information which is not a particular interest of PATOS, but still help us understand the patient's alcohol use and drug use status. Next is arrival type. Inclusion criteria of PATOS limits patients who use EMS for arrival at hospital. Patients would be divided into those who were directly transported from the scene to hospital and those who were rather transported from another hospital. This categorization would lead you to enter different subsequent sections, pre-hospital care or inter-hospital transfer. So please make sure that you select the correct type of arrival in EMS usage. We'll now review pre-hospital care variables. Core pre-hospital care variables include mode of arrival, date and time of call received, date and time ambulance departed from, date and time ambulance arrived at the accident site, date and time ambulance left the accident site, and date and time ambulance arrived at the hospital. We'll also collect information on pre-hospital CPR and initial vital signs and mental status measured during pre-hospital care. And comprehensive variables include incident number and ambulance number. We'll also look at pre-hospital care and treatment variables such as airway, oxygen administration, immobilization, fluid access, and medications given during pre-hospital care. Optional variables would include pain control, procedure for thoracic cavity, diagnosis, and decontamination performed during pre-hospital care. As we saw previously, we'll collect information on multiple time variables. These time variables are very important because rapid transport of severe trauma patients to an appropriate facility is crucial for improving the patient's clinical outcomes. It is important to limit the time interval from incident to treatment to less than an hour. We commonly call this the golden hour. After an accident has occurred, it takes certain steps and procedures for the patient to be transported to the hospital. First, the patient or the bystander must report the accident to the EMS agency, and EMS would then dispatch an ambulance to the incident site. The patient would then receive emergency treatment procedures on the scene and is transported to the destination hospital. Monitoring the time intervals between these steps and assuring their quality would be a very important piece of information for developing trauma care systems. Now we'll take a look at variables related to trauma assessment. An important aspect of pre-hospital care is to clearly assess the severity and to transport the patient to the appropriate hospital. When EMS providers assess a patient on the scene, they usually take medical history and perform physical examination. For trauma patients in particular, primary and secondary surveys are used for severity assessment, and some countries often develop and utilize a field triad scheme. This is why assessment of trauma patients would essentially require measurement of pre-hospital vital signs, oxygen saturation, and mental status. We're going to collect all this information for our PATOS research. There are usually two types of methods for measuring a patient's mental status: Glasgow Coma Scale and ABPU. Glasgow Coma Scale, GCS in short, evaluates a patient's eye, verbal, and motor movement in 1 to 4, 1 to 5, and 1 to 6 ordinal scales, and combines the three scores into a 3 to 15 ordinal scale. ABPU, on the other hand, evaluates mental status in 4 types: alert, voice responsive, pain responsive, and unconsciousness. If you have information on both types of measurement, then we ask you to give preference to GCS over ABPU. Otherwise, you may record either GCS or ABPU, whichever is available on the chart. About mode of arrival, the most widely known type of arrival is ground ambulance, which means that a patient was transported by car. But depending on the geographical and other circumstances, a patient can also be transported by air, such as helicopter or airplane, also by a ship. For pre-hospital trauma care, we need to know whether or not CPR was performed before arrival at hospital. And if EMS providers performed airway management during pre-hospital care, then we need to know about the mode or methods of airway management. Examples would include OPA, combi tube, laryngeal tube, LMA, and ETT. If it was difficult to perform successful airway management, EMS providers may have tried more than one method. For example, if both ETT and LMA were inserted, then we need to record both types of management on the case report form. Similar to airway management, oxygen administration can also be done in multiple ways. Examples are nasal prong, venturi mask, non-rebreathing mask, back valve mask, and mechanical ventilator. If a patient was receiving oxygen via nasal prong but was insufficient for treating hypoxia, then EMS providers may have switched to BVM later in the course. In this case, then we need to record both nasal prong and BVM in the case report form. Pre-hospital immobilization is done to immobilize an injured patient and prevent secondary injury from happening. Examples are backboard scoop, femur traction splint, other extremity splint, bandaging, pelvic binder, and C-spine. And again, if a patient had multiple immobilizations in different anatomical regions, then all types should be recorded on the case report form. If a patient had a shock, then the patient may have received fluid during pre-hospital care. If the patient did receive fluid before arriving at hospital, then we need to assess 3 pieces of information. First is the methods of giving fluid, whether it was IV or IO. Second is the type of fluid given to the patient. And we also need to know about the amount of fluid given to the patient. We will also collect information on the names of medications given during pre-hospital care. You may write up to 10 medications, and we recommend that you enter the generic name of medication instead of the brand name. Next is inter-hospital transfer. As we went over earlier, we're going to collect information on inter-hospital transfer for patients who were transported from other hospitals. This would be a case if a patient visited another hospital prior to arriving at your hospital. A core variable for inter-hospital transfer section is the level of referring hospital. Comprehensive variables include the mode of inter-hospital transfer, reason for transfer, location of transfer, and GCS measured at the referring hospital prior to the transfer. Optional variables will include name of the referring hospital, date and time of arrival at the referring hospital, date and time of departure from the referring hospital, and intervention performed before transfer. We're now going to go over the level of referring hospital, where patients were initially presented at before inter-hospital transfer. For trauma care systems, it is important to categorize hospitals based on their trauma care practice level and regionalize them. This table you see on the slide is the level of trauma centers in the United States. As you can see, hospitals are categorized into levels 1 through 4, where level 1 hospitals indicate the highest level of trauma center. These hospitals are capable of performing basic and specialized surgeries 24 hours a day, as well as training and research. PATOS participating countries would have their own criteria for leveling trauma centers. And in some cases, the criteria used in the States may not be suitable for all countries. So we recommend that each country comes up with its own criteria for labeling hospital levels. Criteria for categorizing trauma center levels may include whether a certain number of trauma patients are admitted to the hospital, whether it can provide surgically directed critical care services, whether it provides education and training programs, and whether or not the hospital conducts trauma-related research. Many Asian countries would have diverse trauma care systems, and we recommend that each country comes up with its own criteria for labeling hospitals into levels 1 through 4. All hospitals in a country should use one unified criteria. For example, in Korea, regional trauma centers are designated across the country, and all hospitals are designated into 3 levels based on their treatment capacity of not just trauma, but all emergency illnesses. Based on this, PATOS Korea is now developing methods to categorize trauma centers with PATOS research. Next is comprehensive variables for inter-hospital transfer. Reason for transfer is why a patient was transported from a referring hospital to the destination hospital. Some options for this variable would include shortage of beds or ICU, absence of physicians who can perform specialized trauma care, and whether the patient was transferred for long-term care or care for mild illnesses. The transfer from where variable asks whether the patient was transported from ED, ICU, or ward of the referring hospital. To investigate these types of variables, it would help you to review a variety of information sources such as medical and administrative records of the referring hospital and doctor's referral note. So this ends Dr. Hong's presentation on basic information in EMS variables for PATOS.